So there's only one case. It says case one, but so she's a nurse, and she's a single mother of two, and her main concern in his life is that she works in shifts, and she tries to work as many shifts as possible, and that will become important in the story down the road. And when she presents, she comes in with, so she's a nurse, she's in the hospital, she has healthcare access and all that, but it takes her 7 months of increasing pain in bilateral hands and wrists. And when you ask her why you didn't come before, because she can't miss a shift, and that's why the first time she had an opening was then, and she came and saw us. At baseline, she is seropositive, not too high, but they're both positive. And an X-ray has no erosions. And on exam, her swollen joint count is 4 and tender joint count is 7, which is our average for the whole database. Tender joint is about 6.2 and swollen is 4 point something. So that's the usual amount of disease activity you see at the beginning. And as we know, any clinical trial has 30 tender and 20 swollen joints. I don't know where those patients come from, but they're less than 10% of the patients we see have that many active joints. This seems to be the median for most series of databases. So this is her. So this is the a simpler version of the flow sheet that we keep on patients. So this is the scores come from the patient questionnaire. Then the database automatically calculates the RAPID-3 score. And then sedimentation rate comes from the lab, and then we also have medications, which we'll get to. And so that's what we do with the data that we collect. Our research assistant enters it for everybody, then prints out a flow sheet, which has this, but has demographic information on the top, and then puts that in the chart. Now, until yesterday, we were on paper charts. As of Monday, we're switching to electronic medical records. I'll let you know how that goes. But that was in the chart, and then you can follow over time what was happening to the patient. And the main use of this is we send a copy of this to the referring doctors. I don't know how it is here, but we don't dictate a letter every single time. There's usually a letter dictated at the beginning when you see the consultation, and then if there are major changes in the treatment. Otherwise, we send this kind of summary thing so that they know what the patient's doing. So here, her function is 4 out of 10, pain is 8 out of 10, global is bad, so rapid is 20, it's more than 12, so she's active. And so ask question, so what did we do for this patient? Just any guess? You can pick a couple things. Yeah, so, because she came to see me, that's what she got. Methotrexate and prednisone. Methotrexate as 10, prednisone as 5. Folic acid also we routinely give. And also she got an IM Kenalog injection, which I don't do all the time, but when we looked at it, about a third of our patients in their first visit get that injection as a depot. And again, she was very inflamed and she wanted to get back to work. I said, all right, we'll give you a shot also to see if it makes you feel better quicker. All right, now that's at the beginning of March. Then she comes back next month, and she is doing better. She's again going to all her shifts as she likes to. Still has some swollen joints and 4 tender joints, but when we look at her scores, her function has really come down. It's down to 1. Her pain is 3, and her global is 2.5. So things have improved. If you add them up, the cutoff for low disease activity is 6. So she's gotten better, but she really hasn't reached that low disease activity. Now, so there's one thing here in the treatment that's going on. I haven't figured out how to reflect this practice in a PowerPoint, but I'll explain it when we get there. So what do we do at that point? So she's been about 5 weeks on the methotrexate and the prednisone. Yeah, so the answer is methotrexate, but so that's what I haven't been able to figure out how to do on the PowerPoint, because she already is told to increase her methotrexate anyway. So what I usually do is I give them a prescription of 8 tablets a week, but she starts with 4 tablets, and then either every week or every other week they're told to increase 1. So by the time she comes here about 5 weeks later, she did it once a week increase, as she tolerates it, and we do that. So she already comes in 20. So this is her scores when she came in the 20. So we kept her on the 20 there, even though she didn't reach exactly 6, she's close enough. And because it's only been 5 weeks, and I would like to wait at least 3 months to see what the maximum methotrexate benefit is going to be, she's doing okay. She responded rather quickly. She's working. Her sedimentation rate is down. Her counts are down. She doesn't get another injection at that time, of course, but she stays on her prednisone and the methotrexate. Then 2 months later, so that was 1 month, so 2 months after the 1 month, so we're at 3 months. So she's about the same with, again, these two, and it's these two MCPs that she has that have been swollen the whole time. 2 swollen and 2 tender joints. And these are her scores. So she's basically the same as she was at the 1 month. So sedimentation dropped a little, but her rapid 3 is, the different components make it up here. So she's a little more functionally, but pain is better. And she's, again, 6.5. And it's been 3 months on the methotrexate now, just above 3 months. Actually, yeah, more than 3 months. Getting close to 3 months, sorry. So what do we do? Add which one? Or do nothing, maybe. All right. So the reason she's here is because she literally fits ideally to the algorithm that we use. That's why. And she's a real patient, so these things actually happen. So we added adalimumab to her, basically explaining to her that she was still doing okay. She's 6.5, but she still has the swollen joints. And because she responded so well to the methotrexate, the main explanation was she has the opportunity to get into full remission if we add a biologic on top of the methotrexate. Now, and her methotrexate is still the same. Now, could we have increased the methotrexate? Maybe, to 25. She's still on 20. I mean, I don't remember why we didn't do that, but that's what we didn't do. Could we switch her to injectable? That would also work too, probably, because you get added benefit when you switch injectable. But again, we don't have the injectable in the US available on a steady basis, so we rarely switch over to injectable. And she preferred, and the reason she preferred adalimumab, because she was offered the same things, that we have 2 injections, 2 infusions. She said, I don't want to do an infusion. And her reason for not doing an infusion was she would have to do it at the hospital, and she didn't want anybody at the hospital to know that she was actually getting a medication for rheumatoid arthritis. So then she said, I'll just do the injections myself at home. And we said, fine, they're both first-line biologics. So she gets on the adalimumab. Then, about 3 months after that, now she's in remission. Her things have come, her pain is actually 0, swollen joints are gone, she has mild things, but her rapid 3 is 2, and she's on the 520 and the adalimumab. So we're happy with that. We keep her on the same things. About half my patients at this point will want to decrease their prednisone. And I tell them, if you really insist, we'll decrease it to 2.5, but we'll still keep some prednisone on board. But she was happy to be okay, and she stayed on that. And that's where we kept her. Then, a year and a half later, she comes back. Now, in between, when I was going through this, she saw me twice, mostly for review of blood tests, and her score stayed the same. But when she comes, that year and a half, the last 6 months, she hasn't been around. And she comes in saying that the last 3 months, she hasn't been doing well. Her symptoms have been increasing, but because of this shift issue, she hasn't been able to come in. And she had to take a lot of time off. She's not back to where she was at 4 swollen, but 3 swollen and more of what she had in the tender joints, 6 joints. And these are her scores. So, I mean, she's not as bad as, and the other advantage of scores is because when she comes in that, she says, I'm back to where I was. And I said, then you look at the scores, no, you're not much worse than where you were, but you're not back to where you were. So you still have but at least you can make that argument to the patient. So yes, so she's at 12, she's at the severe cutoff area. And then we have the discussion saying that, well, biologics tend to fail after 1 year, 1.5 years, 2 years, and maybe that's what's happening with her. And what do we do? Switch. What do we switch to? Or add to? All right. So, as I said, she fits the algorithm perfectly. Because if one didn't work, she goes to the next mode of action. And our list is usually, if they start at TNF, next one is a injectable, infusible. And that time we didn't have injection of abatacept. But she still didn't want to do the infusion because of the same concern of her colleagues, and so we're in Manhattan, she works in Brooklyn, and she works in a Brooklyn hospital. And however, she's also well educated and understands. And after explaining to her, it's probably more important, we can arrange, so we ended up arranging a different infusion center for her that would take her off ours so she can get the infusion after work. But explaining to her, it's probably more important that we go with the best efficacy option than to settle for something that still might work, but it's not going to be maybe as efficacious, at least give her the best chance. So that's why I said the next one is an infusion. Even if you wanted abatacept, it's an infusion. Even if you wanted rituximab, it's an infusion. Even if Actemra, it's an infusion. And I'd rather we try something that has a better chance of working after a TNF rather than staying with another injectable TNF. So then she agreed to do the abatacept, and her weight comes to the 750 dose. And 3 months after that, again, she is in remission. I mean, it's 3 and 2, basically the same thing, but she's on 25, that's never changed, and she's on 750. Now, she recently came back after, I mean, she's doing okay. She's now also not in remission anymore. She's about 5, I looked at before coming. So she's still low disease activity, and we decided to keep her the same because she didn't fall out of that. But she might, next visit, we'll see what happens. She's very compliant with her medications. We actually have done the questionnaire that the patient declares that they were taking their medications as they're supposed to, kind of a thing. I don't know how much it helps, but at least we have some documentation. And just, as I said, she falls very well with her timings and the things we did and responded well, and that's the usual approach that we have to our RA patients for the most part. Now, so summary again. We try to stick to those 3 to 6 months. Now, it doesn't always work because either the patient doesn't come on time or we're not around at that time or we're busy or something happens. But we have a target, which is rapid-3 for better or worse. It works in our patients. And it's no worse than other any measure. And we don't have to spend a lot of time to get the measure. And at the end of the day, as I said, 45% of our patients are on biologics. About 40% are on methotrexate alone. And the rest are on DMARD combinations with methotrexate to get that disease under control. Now, how are we doing? Only about 50% of our patients are in remission and low disease activity. So 50% are still not there if you look at the whole cohort, but of course not all of them are long-term patients. Some of them are just starting, some of them have failed, lots of things. So it's a mixture. But even when we think we're being aggressive and we're measuring, we still do not have 80% remission or low disease activity rates. And that's another reason why we suggest that let's not get overexcited about remission and trying to stop drugs. Let's try to get everybody in low disease at least, or try to get them in there, and then we can decide what we're going to do with our treatments. And I think that's the end of the case study, yes.